I think, the pancreaticobiliary part of advanced endoscopy. So Dr. Buxbaum, welcome.
Thank you. It's a great honor to be invited to this year's Southern California Society of Gastroenterology Symposium. I'm going to be speaking about the best of pancreaticobiliary endoscopy at DDW in 2021. So the three big areas we're going to talk about is what is new in ERCP, what is new in EUS, and what is new in combined pancreaticobiliary endoscopy, specifically looking at NSAIDs plus fluids for post-ERCP pancreatitis prevention, single-use duodenoscopes, glucose for pancreas cyst diagnosis, EUS-guided portal pressure measurements, and the comparative stuff of EUS versus ERCP for biliary obstruction, and EUS gastroenterostomy versus duodenal stent for gastric outlet obstruction. So what is new in ERCP in 2021? So there's the concept of aggressive hydration to prevent post-ERCP pancreatitis. This arose from animal models showing that more severe histologic inflammation in pancreatitis was correlated with decreased blood flow. It was also supported by the early clinical studies looking at acute pancreatitis showing that the initial hydration during the golden hours in the first 24 hours was associated with less necrosis and other unfavorable outcomes. My group actually performed the first pilot study looking at this as a preventative for post-ERCP pancreatitis and showed some positive effect. Subsequently, there was a multicenter randomized trial which showed there was a twofold reduction in all-comers post-ERCP pancreatitis and then moderate and severe pancreatitis as well with aggressive hydration. In the intervening time, however, rectal NSAIDs have come into widespread practice. You see on the right here, a paper from via UCSF that the majority of us are using NSAIDs the majority of time. And the studies of aggressive hydration did not include the concomitant use of NSAIDs. So this prompted the Dutch pancreas group of 22 centers to look at this question. And this flute trial, named after the Dutch sailing ship, but also a play on words for hydration, was a multi-center Dutch trial of 826 patients. It was double-blind. And patients are randomized to rectal NSAID monotherapy versus rectal NSAIDs combined with aggressive hydration, and the main outcome was post-ERCP pancreatitis. The authors found there was no significant reduction with the addition of hydration to NSAIDs, 8% versus 9% post-ERCP pancreatitis. However, there was a trend towards less moderately severe and severe post-ERCP pancreatitis in those who received the combination therapy, although p-value missed significance being 0.09. So the considerations, this is a large multi-center trial looking at the 8-hour infusion protocol and admitting patients actually overnight for observation. There was no difference in overall post-ERCP pancreatitis with the combined therapy. However, this does suggest that the effort time for an 8-hour measure is not merited, but shorter bolus protocols likely deserve evaluation. Additionally, there was a trend to less moderate and severe pancreatitis at 0.09. Therefore, you might be actually treating early pancreatitis more effectively. It also assumed a 60% reduction for aggressive hydration, the same as NSAIDs versus placebo. And as we know from management of hypertension and other disorders, that likely you have to assume a smaller integral improvement with combination therapy. So the jury's probably still not out. The next major topic is disposable duodenoscopes. These were associated with a number of deadly infections. You can see on the right in JAMA, the carbapenem-resistant E. coli concerned us, and we saw news stories like the one on the right about dirty scopes, and it gives us bad memories. And this did prompt the Food and Drug Administration to revise cleaning protocols to recommend new designs to minimize infection. And among these were the disposable duodenoscopes. Here in Southern California, Rama Muthuswamy did the first study in experts showing clinical utility. And at this DDW, Adam Slivka led a multi-center trial across the United States looking at the performance of disposable duodenoscopes in highly experienced, greater than 2,000 lifetime ERCP versus less experienced endoscopists, less than 2,000. It included a wide range of outcomes, including technical success and crossover to a reusable or conventional duodenoscope. And you can see that there was a reasonable group of indications. There was native patients and repeat patients for ERCP. Overall, there was a 9.5% crossover. The authors found that there was no difference, though, in crossover between the less experienced and highly experienced endoscopists, and also no difference in ERCP completion, as well as satisfaction and adverse events. And this was broken down to ASG complexity scores, which describe how difficult a procedure is. There was similarly no difference in crossover rate between the 1 and 2, the fairly easy procedure versus the more difficult 3 and 4s. The mean procedure time, though, is expected somewhat longer for the more complex procedures. So the implications are that disposable duodenoscopes minimize risk of infection from patient to patient, obviously, because they're thrown away after each case. This is appealing to patients. They're technically useful for operators with variable experience, as this study at DDW shows. There's also a smaller multicenter European trial which came to the same conclusions. They're lighter, they're actually customizable, and they do minimize the use of sterilization equipment. On the downside, they do cost around $3,000 per scope. There is still a 10% crossover. Therefore, there is some limitation of performance. And there's also less duodenoscope infections, fortunately. In 2015, there were 250 reported in the United States. In 2019, there were 45 reported. There's also concerns about greenhouse emission with their production. So what is new in the world of endoscopic ultrasound? So you can see here what advanced endoscopists spend a lot of time is performing fine needle aspiration, fine needle biopsy of pancreas cysts. And our concern is that these cysts are a main precursor of pancreas cancer as they progress. The primary marker we use to differentiate mucinous, which are precancerous cysts, from other pancreas cysts is the carcinoma embryogenic level, or the CEA level. Often used 192. Columbus sailed the ocean blue in 1492, so it's easy to remember. But the performance of CEA is actually quite variable. It goes anywhere from 30 to 100% for the sensitivity if you look at the variable studies. So there's room for improvement. And there was a multi-center study at this DDW from Cleveland Clinic, Spain, and Wisconsin looking at fresh pancreas cyst fluid, glucose, and CEA. And the interest is in low levels of glucose being predictive. And this study had a histologic confirmation of all the cysts. You can see that about half of these were from actually operative resection. The other half were from US with biopsies and US with core sampling. About 2/3 of the cysts were mucinous overall in this study of 93 patients. And what they found was that both for a intracystic glucose of 39, as well as a glucose level of less than 25, there was improved performance. For example, sensitivity and specificity were 88 and 91 versus 61 and 88 for CEA. And the accuracy was better at 89 versus 71. Looking at the ROC curves, there was a significant effect over the different levels for glucose. So it's quite interesting. The major thing we're doing currently in practice is using genetic testing with a variety of available kits from different manufacturers. Some of these are expensive, and they're not always covered by insurances. And they're also send-out tests. Glucose is a readily available, inexpensive test in every hospital, and the process can be implemented in a very simple manner. However, large validation studies are needed before we really routinely use this. But I suspect this will be picked up quickly given how widely available this is. The next exciting thing, which you saw a little bit on Friday, is the portal pressure gradients. So a gradient greater than 10, as you know, is predictive of complications of liver disease, including varices and actually survival. And classically, we measure the portal pressure gradient using wedge catheters, very similar to Swan-Ganz in cardiology. The catheter with the balloon down goes in the hepatic vein, you get a measurement, you blow up the balloon, it gives a sense of what's going on in the portal vein. The issue is that this is invasive, requiring a jugular access. It does have limitations in those who have clotting disorders like Budd-Chiari, and also underestimates portal hypertension in those with pre-sinusoidal causes like schistosomiasis. So the new method, this video is courtesy of Kenneth, sent it to me, is a direct measurement. So what you would aim to do is around the G junction, you access first the hepatic vein or a branch of the hepatic vein, get a measurement. There's a bedside manometry catheter, which is hooked up to this very small needle. Here, for example, it's 13 for the hepatic vein pressure. You then advance the US scope further, either into the distal stomach or into the duodenum, and then you actually access a area of the portal vein. This is a very small needle, it's 25 gauge, and as the endosonographers know, we inadvertently access the portal vein frequently. And so here it's 14 or 15. So this patient didn't have portal hypertension because you take the portal vein minus hepatic vein, 15 minus 13 here, and it's 2. So this DDW was the first multi-center study of U.S. portal pressure gradients, looking at clinical outcomes by group, including the Irvine group, but also Mayo and the Brigham. And the goal was to correlate the pressure measurements with a number of markers, including varices, low platelet count, but also several different scoring systems, including MELD, APRI, which is AST to platelet ratio index, and FIB4, which is the fibrosis 4 score. They included patients, the dominant diagnoses were NAFLD and unexplained liver test elevation, but they also looked at those with a whole cadre of liver diseases, as well as ranges of scores, although most were Child-Pugh A. And as you see, there was a strong correlation with the EUS portal pressure gradient with the variable outcomes, including varices, gastropathy, thrombocytopenia. Across all of these, there was also strong correlation with the scoring systems, especially the FIB4, but also MELD and APRI. So EUS portal pressure gradients correlate with clinical manifestations of portal hypertension, as well as the scoring systems. They do represent an endoscopic one-stop shop. When you're doing your variceal screening, you can do a quick biopsy of the liver, you can measure the portal pressure gradient, maybe do some shear wave elastography. I'm interested in contrast, maybe we can add that to it. So it's the beginning of this concept of endohepatology. However, this is a delicate system. For those who've used it, it's difficult to calibrate it. Also, the real-world impact isn't yet defined. Clearly, we have a strong history of using the IR approach. Interventional radiology is also somewhat a one-stop shop, if you think about it, because they can do a transjugular liver biopsy. They can even place a TIPS at the same time. So I think there's going to be a lot more about this shortly. So the third big area today is what is new for combined pancreaticobiliary endoscopy, and it might be more accurate to say what's new for competitive pancreaticobiliary endoscopy. So currently for malignant obstruction, distal obstruction, the standard approach is to do EOS, a self-expandable metal stents, in which we place a wire across a stricture, then followed by placing a stent system, and then releasing a wire or different mechanism to deploy a stent across the actual tumor itself. A newer approach, and this video is actually sent over by Anthony Teo, is to do EUS-guided drainage, in which you take first an EUS needle, you puncture into the bile duct from the duodenum. Typically, then we do place a wire in contrast to evaluate where we are. You can see on the scheme on the right what this looks like. And then eventually a lumen-opposing stent is placed, typically cautery enhanced nowadays, into the bile duct. This is primarily still being done in Europe, though, and Asia, given FDA limitations. But then eventually this connector is placed, and now you have a endoscopic choledochoduodenostomy, a CDS. And the advantage here is that you plan to basically avoid the whole area of the tumor. So theoretically, there's less ingrowth, and it should improve patency. You're basically pouring a bypass instead of going across the tumor. So there was a large multi-center randomized controlled trial from all over the world presented by Anthony Teo at this DDW. And the group randomized 164 patients. And these were patients that didn't have duodenal obstruction. So his idea was these would be more representative of patients that could go either way. So they did either EUS with choledochoduodenostomy or ERCP with a self-expandable stent. And they randomized the two approaches. And the main outcome was a 1-year patency rate determined by ERCP or determined by endoscopy. But also looked at a number of other outcomes, including technical success, time, adverse events. And what they saw, there actually was no difference in the 1-year stent dysfunction between the ERCP with self-expandable stents or with EUS choledochoduodenostomy. It was 9% in both groups. They did find that there was initial technical success was higher with EUS choledochoduodenostomy, although eventual clinical success was comparable. It also shortened procedure time, 15.6 minutes versus 28.7. And this makes sense because these are often difficult ERCPs due to the high-level obstruction. So EUS with choledochoduodenostomy it should start to be considered a primary drainage procedure. It's likely favored for patients who have duodenal obstruction. It has comparable efficacy to ERCP, but the longer-term patency data is pending, so it's not really clear whether bypassing the tumor does improve the long-term patency, even though it makes sense. This study didn't show a difference yet. They are going to work their data out, though, for another year. However, there is widespread expertise with ERCP with decompression. Using EUS drainage approaches does require a new skill set, and probably most importantly, we don't fully know the adverse events yet. There's things like big bleeds and bile leaks that might make us more squeamish about this, that we probably have to see what happens over time. Our last area is gastric outlet obstruction. So GOO happens from peptic disease and benign things, but most of the time as endoscopists, we deal more with pancreas cancer, cholangiocarcinoma, or duodenal cancer causing this. And studies have shown that duodenal stents, in which you place using a wire system very similar to ERCP and then slipping a metal stent, does shorten time to recovery and allows early resumption of enteral nutrition. So it tends to be favored, particularly in patients that have more serious or more advanced malignancies, which is typically who gets referred for this. There is a new approach in this video to the left where basically an EUS scope in the stomach is used to needle into the loop jejunum. This is what's happening on the right. They're passing, and then a wire is passed to secure position. Sometimes dilation is performed. Here you see a dilation. More frequently now we're using cautery-enhanced lumen-opposing stents to actually cut and create a connection between the two areas and then deploy a self-expandable metal stent, which is happening here. And you basically then go from the stomach into a loop jejunum, and then you now have a creation, a endoscopic gastroenterostomy. So this was a hot topic at DDW. There's actually a whole session that was pretty good that each had kind of small points, and so I just want to quickly show these three things actually. One was a study led by Hopkins, but Multicenter. There was another study from Virginia Tech and Stanford, and then the last one was actually from here in Southern California from the Cedars group with Ulysses Rosas presenting. So in terms of the first one was a Hopkins study, and they were looking at a huge group of 467 patients who had this from all over. And what they found was actually quite startling. There's a 10% migration of these lumen-opposing stents out of position. And they characterize them as type 1 if the stent just comes out, but there isn't an injury to the jejunum, or type 2, and there's now a tear or an enterotomy in the jejunum after you've done this and it's come out. And what they found is about 11% of the time the patients were required to go to urgent surgery. But in most of the cases, 83% they could do endoscopic closure and notes, and some managed conservatively. The second interesting concept on this came from a really group at Virginia Tech. So they compared antegrade, which is the approach I showed you earlier, where you go from the stomach to the jejunum to do this, with retrograde, where you actually put an EUS scope through the stomach, duodenum, to jejunum, and then you go from the jejunum into the stomach. And they found there was a big decrease in adverse events, went from 14 to 0 with retrograde approach. The global question, though, is if you can get a whole EUS scope through, do you really need to place a stent anyway? And their point is these are the patients that have impending symptoms and obstruction but aren't totally blocked yet. And they tend to do better, likely because you have a much bigger target for the needle and the access system. Finally, the group at Cedars performed a match study where they matched 25 patients who had gastroenterostomy with those who had duodenal stent on a number of factors, including type malignancy, age, BMI. And they were really looking at 30-day readmission. And so they found that there was actually longer procedure time for the EUS gastroenterostomy, 75 minutes versus 48 for duodenal stents. But the adverse event, readmission, and other points didn't have any significant differences. But what was very interesting is that the ability to take more food, soft or solid diet, was earlier for those who had a gastroenterostomy. There's also less readmissions for malabsorption and metabolic changes with the gastroenterostomy, and there was less need for either tube feeds or TPN. So EUS gastroenterostomy may improve nutrition for gastric outlet obstruction versus duodenal stent. Patients have similar technical success, and it's definitely a major approach for failed duodenal stent. The issue, though, of stent migration is serious still. They are longer procedures. But what's interesting is there may be an earlier role for early GOO, so patients are just starting to have symptoms, possibly from the retrograde approach. Also, that they may have better nutritional support for these patients. What's likely needed, though, is better tools, maybe T-tags or anchoring systems to make it a little bit safer, and then it really may emerge as the primary approach. So our takeaway points from pancreaticobiliary endoscopy DDW 2021. For ERCP, the addition of aggressive hydration to rectal NSAIDs does not prevent post-ERCP pancreatitis relative to NSAIDs alone, but it might mitigate its severity. So stay tuned. Disposable duodenoscopes have comparable performance to reusable scopes, and this includes even among endoscopists of variable experience. They minimize infection risk, but they are more expensive. EUS, there's low intracystic glucose levels, left level less than 25 milligrams per deciliter. Appears to be an inexpensive, readily available marker for mucinous pancreatic cysts, which may improve its performance relative to CA or be combined with CEA. EUS with portal pressure gradient measurements, there's now a commercially available system for this, and appears to correlate now with clinically important findings like varices and portal hypertension scores. And in terms of multimodality or competitive pancreaticobiliary endoscopy, EUS guided choledochoduostomy for malignant obstruction appears to be comparable in success relative to ERCP with SEMS. It's not definitely better, though. It's not clear that it improves patency rates. And this does also require a certain skill set. EUS guided gastroenterostomy with lumen-opposing stents may improve nutritional status relative to duodenal stents. But again, there is a significant migration rate, skill set, and likely more tools needed for this. I'd like to thank you for your attention and the opportunity to speak today.
Okay, our next speaker is doing double duty at this meeting. If you missed it, our next speaker had an amazing poem case on the LA Live